Good morning. I'd like to get started with today's event, so if I could get everybody to come on inside and have a seat, I'll give you a little bit less than a minute to get settled and we'll get started. Okay. Good morning. I'd like to introduce myself as the new director for the Center for Health and Biosciences here at the Baker Institute. Welcome. It's such a pleasure to have everybody here in person and without masks, at least most of us. It is my pleasure to welcome you to today's event addressing financial toxicity in healthcare, the physician's perspective, hosted by our Center for Health and Biosciences at the Baker Institute. Our Center for Health and Biosciences is a global think tank, and we are dedicated to the translation of critical research in the areas of public health and medical science, and translation of this research into real action, community interventions, and public health policy that ultimately improves the lives of all people locally, nationally, and globally. Our mission and our vision to the future is to continue the outstanding work that we have already accomplished and expand upon it in the areas of child health policy, healthcare economics, vaccine diplomacy, and science innovation, biotechnology, and healthcare innovation. Furthermore, the CHB is really embarking on an exciting adventure in the next couple of years where we would like to expand in new areas of critical research. Some examples of those areas include mental health, refugee and immigrant health, environmental justice, health equity, and firearm injury prevention and safety. In collaboration with our outstanding researchers and scientists and medical institutions in the Texas Medical Center, as well as our critical stakeholders and legislators, we hope to ensure that our CHB will continue its significant impact on our community locally and globally. We appreciate your support and recognition of this critical mission as a center, and I welcome you to join us in our future expansion efforts. We will be hosting several events in the upcoming year. We are having a firearm injury prevention and safety event on June 21st, where we will engage local and state and national stakeholders in a discussion in this critical public health area. We are also hosting a multi-center stakeholder symposium on liver cancer on September 17th, which happens to be the fastest growing cancer in the United States, and Texas actually leads the state as the the highest prevalence of liver cancer. We are also in process of planning an important event over the summer in July, which will include conversations on health in the midterm elections. So please look forward to these events. We really would love to see you here. I would like to introduce our moderator today in our critical discussion. Dr. Vivian Ho is the James A. Baker Institute Chair in Healthcare Economics and a leading expert in health economics. Please join me in welcoming Dr. Ho.
Thank you, Dr. El Sarag, and it's good to have you all back in person. It's so great to see you. Many of you are here for the first time. Welcome. Glad to have you here as well. I'm just going to do a brief introduction of our two speakers. The full program, if you have a cell phone with you, you can scan the QR code on your table and see how this is going to work. We're going to have two speakers who are going to talk for 20 minutes each. Then we're going to have a little bit of discussion. I'm going to maybe try and put their feet to the fire. And then we'll have question and answers from the audience at the end. We are going to wrap up at 10 o'clock. So just very briefly, the full bios are actually, you can read them through your cell phones, but we're fortunate to have Dr. Khurram Nasser from Methodist Hospital with us today, and Dr. Anyeze Afadile from MD Anderson. If you don't have your cell phone with you, just one brief title. Dr. Nasser is the Division Chief for Cardiovascular Prevention and Wellness at the DeBakey Heart and Vascular Center, and he has many other titles. We're fortunate. If you actually do a Google Scholar search on Dr. Nasser, you'll realize that he is one of the world's renowned experts on atherosclerotic cardiovascular disease. And actually, if you're a scholar nerd, you'll see that his H index is triple digits, which is just completely mind-blowing. And so you'll see that, but he is going to be talking about financial toxicity, which is one of the things he cares deeply about today. So, and we're lucky to have Dr. Nasser here in Houston. He moved with us just about prior to the pandemic, and so has not many people have had a chance to see him speak. Dr. Alfadile has been here in Houston for longer, and he arrived here as an assistant professor in plastic surgery at MD Anderson, and also did some fellowship training there. He is also the director of clinical transformation at the University of at MD Anderson, and he. I guess what he says, he calls himself looking at the macro environment of plastic surgery because he looks at all the types of healthcare delivery system factors that influence what he does in the hospital. So he looks at the workplace, he looks at policy. I was very fortunate that Dr. Alfadile included me in his efforts to study private equity acquisition of hospitals and what it does to cost and quality. His article was actually the 10th most downloaded paper from Health Affairs in the country last year, which is quite an achievement. And so with that, we're moving to financial toxicity. The two physicians are going to introduce a topic to you and explain everything, and I'm just going to get out of the way for now.
Okay. Well, thank you, Rola and Vivian, for the opportunity to present today and for the kind introduction. So, like she said, my name is Anyezo Fudle, happy to be here. And two things, my talk will be fairly high level, really introduce concepts describing toxicity and how it plays out in a cancer context. And I deliberately chose this photo, a very sort of uplifting, optimistic photo, because I think it best frames what's at the heart of the issue. So the way I think of financial toxicity is it gets in the way of that, right? So what that is a therapeutic alliance between a doctor and a patient. And toxicity really is a barrier that impacts how often that happens and the extent to which that happens. So I think a good way to start off is this paper that came out last year. Everyone can hear me, right? Yeah. It came out last year in JAMA, and it was done by really phenomenal economists across many institutions, and it was the first really empirical work that quantified the level of medical debt. So it's about 18% in the US. So they use credit reports over a long period of time, as you can see, and the top line finding is this is sort of a US only reality. So most industrialized countries do not have medical debt to that level. And what he also showed was, for the first time, circa 2014, 2013, medical debt outpaced all other forms of debt from collections. So this is defaulting car notes, defaulting mortgages. And when you quantify the total amount of medical debt, it's about $140 billion would it be. So this is a pervasive problem and a persistent problem. But also, another work done by the Kaiser Family Foundation this year sort of did a deep dive. So in the prior slide, really the bulk of the debt was in the $250, $300 range, as in the median debt. What they showed in this paper was actually most people who have debt, as you can see, well over 50% report debt over $1,000. So the level of debt is in itself not insignificant. So this sort of sets up financial toxicity. It goes by many names. Some people call it economic distress, financial hardship. And what it really is, so this graphic is from JAMA Oncology this year. What it really is the negative impact, right, of the high cost of cancer treatment. I will add indirect and direct cost of cancer treatment on a patient's quality of life. I'll also add patient and family's quality of life, and I'll get to that point shortly. And really, the way it plays out is in three main buckets. So one bucket is what I call sort of coping strategies, and that's listed here. Skipping doses, not filling prescriptions, reducing spending on travel, food, clothing. The second bucket is actually material hardship, and that is debt, borrowing money, refinancing your home. And the third one, which really informs the bulk of my research group's activity, is really kind of quantifying the psychosocial impacts of toxicity. So that's anxiety, stress, depression. And in many ways, financial toxicity is a concept that was born out of cancer. Why cancer? So cancer is the second most expensive condition per capita in the US, second only to heart disease, so Coram will talk about that. And the drivers within oncology is, one, to diagnose and treat cancer requires a lot of stuff, and these things have a cost associated with them. Number two, particularly at the end of life, there is a fair amount of treatment intensity, or I would say overtreatment, which really sort of comes to bear in this way. And lastly, with this entity of high deductible health plans, it really is prevalent in oncology. So depending on how you count it, up to 73% of cancer survivors report financial hardship. And the way it plays out, and I'll get to this in a second, is worse quality of life, bankruptcy, symptom burden, and treatment non-adherence. So in many ways, a cancer patient's journey is really best exemplified by this. So the dashed horizontal line is the allowed amount per month for a diabetic. So that's a fairly common chronic condition, and that's a useful baseline. So time zero is the sort of point of cancer diagnosis, and this is 3 of the big 4, so lung, colon, breast. And the first thing you see is this really logarithmic spike in spending, right? And I'll point you to the upper end of the y-axis is no longer linear, it actually becomes logarithmic, so it goes to 10,000, 15, 20, 25,000. So the way I will describe this is basically an economic shock that was unexpected, right? And the second thing I'll point out is this shock really takes up to 3 years to really settle down, but the new baseline is higher than the pre-diagnosis baseline. So people really never bounce back, so to speak, from this context. So cancer care is abrupt and expensive. Okay, but what does that tie into this? So this feature of cancer care sort of ties in directly to bankruptcy. So this is work done by Scott Ramsey at University of Washington, and I think the dashed lines point out Bankruptcy Reform Act. High level is a new law. It's not so new now, but I made it more difficult to file for personal finances protection in bankruptcy claims. So what you see is cancer patients in red who sort of have a condition compared to matched patients, so all non-cancer. Pound for pound, lack of a better word, cancer patients sort of have a higher risk of bankruptcy across the board. And even after the reform, you can see things pick back up. They sort of had a higher risk of bankruptcy. So it's the leading cause of medical bankruptcy in the country. And how this plays out is bankruptcy in of itself is an independent risk factor for mortality. So same group, different journal, they took about 7,500 patients and they matched a cancer patient who had bankruptcy to a cancer patient who did not have bankruptcy. And what you see, and they balance for age, stage, treatment history. And what you see is across the board, sort of cancer patients who have a bankruptcy episode sort of have a higher sort of odds of mortality, all-cause mortality, and that's real. So in many ways, the way I could reframe toxicity is a condition that's treatable, but if left, leads to worse all-cause survival, right? And breast is sort of my research focus, a similar trend there. So this was pretty compelling, and this really, in many ways, really put this issue on the map, at least in the health services research domain and policy domain. So I alluded to the 3 domains of toxicity. One is material conditions, out-of-pocket payments, missing work, reduced income, medical bankruptcy, psychosocial response, depression, feeling distress, anxiety, and these coping behaviors I mentioned earlier. I think the key thing is when you put them in the framework, you can see how, unfortunately, they are in a vicious cycle and unfortunately reinforce each other. So this framework shows the causes, so baseline factors, cancer stage, insurance, treatment exposure, consequences, so those domains, and how they feed back. So someone has cancer diagnosis in the context, he or she will have to take time off of work to meet their treatment. So less work, less income, less productivity. That means they have to deplete their savings, increase debt. That causes more distress and concern, leads to more debt, worse quality of life, and just unfortunately feeds back in that vicious cycle. And ASCO, American Society of Clinical Oncology, did a national survey to get a temperature of the specialty. And what they saw was, among survivors, they were more preoccupied or concerned about financial burden over life, right? And number two, when they focus on the caregivers, 61% of caregivers, so not the patients themselves, reported in many ways exhibiting financial toxicity. So a good chunk of them dipped into their savings, worked extra hours, delayed retirement, took additional jobs, had a pervasive worry as well. So in many ways, toxicity is as much a burden on patients as it is a family. And I think conceptually it should be thought of as a unit. And this has led to a lot of scientific attention in scientific press and lay press. But what I think is really compelling is, for instance, a patient will never use the words financial toxicity to characterize what they're going through. So what we did with collaborators at Duke, we actually sort of looked to see, okay, how would a patient describe, in this case, a breast cancer patient, how would she or the partner describe what they're going through, and what are the main themes? And there are several themes, but the three that I thought were most illustrative was one, this idea of limited resources, right? So these are direct quotes from the paper, and I'll also allow people to read as I advance through them. But limited resources is a big one. Career disruption, right, is a big one. And this idea of indirect costs. So people have to travel long distances to either come to seek care, and that travel distance sort of is disruptive. You have to take time off of work, get a babysitter, find temporary lodging. So I think these are the themes as I, in my practice, engage with patients, I'm sort of on the lookout for, because, like I said, financial toxicity in some ways is medical jargon, and the way people really describe this experience is, I think, in these sort of descriptive quotes. Fortunately, financial toxicity can be quantified. So there was a patient-reported outcome created in Chicago. It's called the COST, appropriately enough, that we use, my group uses as well, to really sort of get a sense of toxicity in a very validated way. And when we think about who is at risk for toxicity, I'll point you to the systematic review, came out 2019, and they have about 75 studies, give or take, well over 600,000 or almost 600,000 patients across all the studies. And the key themes I want to call out is one, a little under half of cancer patients at some point endorse some form of toxicity. And the typical risk profile is an uninsured patient, which kind of makes sense. And the odds of toxicity is about 2 times. A patient who's lower income and a patient who's young. Unemployment status does indeed sort of play in as well. From a timing standpoint, early in the treatment seems to be when they are most sensitive to toxicity. And there's been no major variation with respect to cancer site, lung, breast, colon. They all sort of play out the same way. And the key thing is toxicity really translates, in addition to worse survival, they also translate to worse quality of life, both from a global quality of life standpoint, as well as a condition-specific quality of life standpoint. And it also plays out this coping behavior I mentioned with medication non-adherence. So it's a difficult problem, right? And I think in many ways, it's one that requires solutions to really sort of cut across the ecosystem of healthcare. I think on the patient level, if you think about more health literacy, more nuanced sort of benefits designed for patients. From provider, I'll get to that in a second, but cost conversation is something we could do more of. Institution policy all comes to bear. So whatever solution we come up with must exist with this reinforcing sort of framework across the system, institutional, and interpersonal level. And one potential solution that at least I'm personally excited about is the idea of financial navigation. So this is work that my group, we collaborated and put this out actually this month. And what it is actually financial navigation is a health system level intervention. And essentially, you can think about it as sort of creating tailored interventions at the patient family level to reduce or sort of circumvent barriers to financial burden. And in many ways, it could be as simple as offering money, and many times it does involve offering money, whether it's copay assistance or direct grants. I think what's more compelling about this is actually it also involves teaching patients about sort of their financial commitments, helping people with their disability employment benefits, and also helping people with budgeting. So very nuts and bolts of like care related to financial services. So it's been shown to be feasible and scalable at the institution level, and pretty compelling evidence that is enlarging that if you implement financial navigation, you reduce both the severity, the duration, and the onset of financial toxicity. So it's a pretty compelling narrative. What can we do as physicians? So obviously I'm a plastic surgeon, so I took a very plastic surgery lens, and we sort of created like a checklist of things that we should consider. So one is, first of all, just having cost discussions. I'll get to why that's compelling, but I think this is a charge of everyone in the care team, the surgeons, the trainees, the nursing staff, and our role is not really to go into an in-depth discussion about financial toxicity, but two things. One, create the emotional space for a patient to consider these issues. You can imagine for some patients it's a fair bit of shame. Say, I have cancer, I'm trying to extend my life, and there may be a perception that worrying about cost is inappropriate. That is not true, because if I've shown that financial toxicity sort of dampens life expectancy, then it's something that we should all be engaged with. And secondly is screening tools. So we have done some research that shows that sort of cost tool, leveraging machine learning techniques, can be scalable in a clinical workflow, and there's a certainly good benefit to thinking about that. And then de-emphasizing low-value care. So there are a lot of things that we do as clinicians that really doesn't have that much bang for the buck, but we do it anyway. Well, those things have a cost structure associated with them. So if you could avoid them, de-emphasize them, then I think that certainly helps patients move along. And then where reasonable, if you could change the care plan, whether it's offering generic medications, consolidating post-operative visits, so you have to make 2 trips to see me and the medical oncologist or the cardiologist, that certainly helps out. And lastly, sort of implementing financial navigation, we think has a distinct benefit for patients. So to close it out, why are cost discussions so important? So work we've done has shown very low prevalence of cost discussions in general across the entire cancer ecosystem, plastic surgeons, surgical oncologists, radiation oncologists, just very low levels. And it begs the question, well, why have it? A couple of things. One, like I talked about, we're creating an emotional space to have those deliberations, which I think is the most important thing. Number two, these discussions take 33 seconds. They actually don't take that long. So no clinic is that busy where we can't have a discussion, a meaningful discussion about cost. And the role is not to, like I said, have this in-depth sort of like thesis, but more to surface a concern. So for instance, an easy thing I do is I ask a patient, if you had a sudden bill for $200, could you meet that? And if someone cannot, then that's a strong signal that there's some risk for toxicity. And cost discussions do indeed reduce toxicity because you're able to map to interventions. And lastly, most importantly, cost discussions does indeed drive decisions in cancer surgery. So this work done at Duke showed that in breast cancer surgery, for almost 30% of patients, cost considerations directly impact the decisions they made. And particularly in these women, actually cost discussions actually was a priority over breast reconstruction. So this is my last slide. I want to just sort of call out, there are many resources to address toxicity. Many of them are free. And by way of disclosure, this organization, Patient Advocate Foundation, I'm on the board as a result of my work. And thank you so much.
Good morning, everyone. Vivian, Ola, thank you so much for having me. And what an amazing introduction on this topic, as now you can clearly see financial toxicity can be seen as a broad set of detrimental effects from the medical care cost on the well-being of not only individual, families, and the society. And as Vivian pointed out, I'm a preventive cardiologist. I deal a lot with atherosclerosis, trying to find people who have heart disease. So how did I even get involved in this space? Well, it wasn't by choice. When I look on into that, it started almost a year, I would say 5 years back, when a very good friend of mine, uninsured, a small business owner, had a heart attack. And thankfully to the magnificent advancements that we have in access and therapies and medical care. He survived. He had a VFF arrest, resuscitated, and to the joy of the family, in a couple of weeks was back home. But those were short-lasted because he got hit with a $150,000 medical bill. Now, that was a shock for us, him, and his family, and, well, we figured it out. We worked with the institution, cut it back, and even now, he's still riddled with debt that he's slowing paying back to the system. So, you may think, well, this is one of the anecdote case of the perils of being uninsured, but that's not true. Even in our own backyard, in Texas, Drew Calvin, a school teacher with insurance, had a heart attack. His friends took them to the nearest emergency. He was insured, but he got almost a $110,000 bill because he was out of network. Now, you would wonder what are these costs would be, and if you go through list by list, $200 for a blood test and about $25,000 for a stent, these are all markups, and then eventually, in case things that had been shifted to the uninsured. So it's not really that, of course, you pointed out uninsured being a high risk, but underinsurance and out of network is a big issue and challenge too. So does anyone know who this guy is? Leon Letterman. So this is Leon Letterman. He won a Nobel Prize in 1988 for discovering the God's particle. Now, in 2015, he had to sell his Nobel Prize and gold medal for $765 to meet the mounting care that was existing. He had Alzheimer's, dementia, and he died in a nursing home. Now, I think this is a great example of what's best and worst in America. So he was born in 1920, and his father worked in a laundry, and then eventually he went up and won a Nobel Prize, but at the same time was not immune to the rising cost. Even a University of Chicago professor, a Nobel Prize, to the rising cost of healthcare that affects all of us here and many individuals beyond. Now, not only that, what about Heda Martin, who was rejected a transplant and was asked to start a GoFundMe project to raise $100,000. She's one of the 250,000 individuals each year that raise almost $500 million for medical care, and which is now a testimony of, I would say, the ailment and the challenges that we all face from medical care out in here. So, and of course, you and I would think this is all about acute care. You had a heart attack, you had a stroke, you had a bypass, you need that, but it's not all about acute care. I'll give you an example. I had a 68-year-old male, Medicare Advantage, earns $80,000, and I prescribed him one of the very few medications in cardiovascular disease that have shown to improve outcomes, reduce the risk of stroke, heart disease, and even death. And in 4 months, he had to stop his medication because he was paying $300 out-of-pocket cost. And this is a PCSK9 inhibitor. Most of us may be well aware of that. And again, he's not alone. It has been shown 60% of these individuals, where apart from the insurance barriers where they may not get the prescription, but even if you do that, about 60% of these individuals have to stop because of the cost. So don't take me wrong, and you can clearly see out here that how many, about 30% of these individuals, once you get into the 300 cost, are going to stop the PCSK9 inhibitors. And as I was thinking about it, as a preventive cardiologist, I'm not here to paint a gloomy picture. And I think so we have made a huge progress with advancements in access, therapies, care, key performance indicators, ensuring we are falling to a point that hopefully in the next 10 years, we may lose the tag of the #1 killer disease in US. But it has come with a price. So in 2020, the direct and indirect cost for managing heart disease is $500 billion and estimated to go up to $800 billion in the next 10 years. We think almost $1 in $6 that we spend in healthcare is on heart disease. And clearly, now we have seen the trend where payers, be it private or government payers, are shifting the cost to the patients and their families. And clearly, as we have seen that now in US, more Americans fear medical bills than becoming seriously ill. About 40% fear more about the bills than becoming seriously ill, which is 1/3. And survey after survey, you will see that unexpected medical bills, health insurance deductibles, prescription cost, trump the basic staples of life around paying your mortgage, for food, travel, and basic necessities of life. So this is where we live. And in this construct, influenced by some of the events by family members, talking to my own patients, seeing what's happening in society, and of course, seeing so much work done in the oncology field in 2017, started asking question to ourselves is, we pride ourselves in doing the best for our patients. Are we becoming a part of some problem? So how much of heart disease patients are paying out of pocket? How much their families are spending out of their pocket of their total income? Are they able to pay medical bills? Who are the most vulnerable? What about insurance? Medication, which is the key thing in preventing heart disease, which is what I do. Are there other unintended consequences and outcomes? And you would see that in 2016 and 17, when we started asking question, really the cupboard was empty. There was nothing that we knew all about it. So this came to me as a pretty surprise in how financial toxicity is well defined, adopted, studied, and actually interventions being planned, but nothing was happening in cardiology. So we're pretty late in this journey. But we have to start somewhere. So working with colleagues at UT Southwestern, Star Fellow Rohan Khera, we started digging deep into it. And we found like 1 in 7 families with heart disease are spending 20% of their entire family income on healthcare, which is considered high financial burden. About 2.5 million families, but 1 in 20 are undergoing catastrophic financial burden. That's defined by the WHO if you're spending nearly half, 40% of your entire income. But the sobering part and the sad part here is that not everyone's affected equally. Low-income families are 4 to 10-fold higher risk of high financial burden and catastrophic financial burden. And that too, even with the introduction of the ACA, although we saw a little flattening, but not to the point that it would make any dent. Now, where are we spending? Truly, the average cost is around $227,000. 1/3 goes on to insurance, but the non-insurance premiums, medications, contribute almost half of the non-premium out-of-pocket cost. Now, I'm talking about an era where we do not have as expensive therapies as in oncology. So this is pre-PCSK9, which is the injectables, and the new cardiometabolic therapies that are coming that are more expensive. So truly, this is where we are at this situation. But this is an objective measurement in actually how much you are spending. But it doesn't take into account other measures. For example, as we talk about childcare, transportation, $2,000 for me may be different than somebody else. It all depends upon your own wealth and needs. So objective measurement becomes even more important. And it was even more sobering to realize that when we started looking into national data that looks into how do these patients pay medical bills. Are they paying off with credit card, personal loans, making arrangements, asking their friends? So 1 in 2 individuals with heart disease have difficulty paying medical bills. Majority of them are able to pay it over the next 12 months, but 20% are unable to. The most vulnerable as almost similar, low income, uninsured, young, racial minorities. But the thing that truly stuck us is 70% of these individuals are insured. So while we are pretty clear about the menace of uninsured, this is a big thing that's brewing under the hood, is this growing challenge of underinsurance. In cardiovascular disease, medication adherence is a key thing that helps keep you healthy, your cholesterol, your blood pressure, your glucose in check, reduce the risk of you having downstream unintended consequences. And non-adherence has been a big issue, but how about cost? Finally, what we found that 1 in 8 Americans cannot afford their heart disease drugs. And they're skipping, they're not picking up the prescription, they're cutting in half. 2% of these individuals are asking, actually raised up the flags, are asking us for solutions. One in 5 of these individuals are using alternate therapies. So again, this is the scope which I think would have been worse now after the introduction of more expensive medication. Same thing with foregone medical care. Heart failure is a condition where you need more access, more closer follow-up, maybe more imaging testing and more medication. 1 in 6 patients with heart failure forego their medical care, and half of them are doing due to cost. And it has consequences downstream, even to the society and peers, because these are the individuals which are much more likely to present to the ED, have a higher inpatient cost and a total healthcare cost. So at some point, from a policy standpoint, we also have to look at where we can make an impact and overcome these challenges. So the big picture is definitely we knew that financial toxicity is much more prevalent, maybe more relevant in cancer, but in this recent study, what we found that among patients with cardiovascular disease, the risk or the burden may be almost similar. And of course, now with growing survivors with cancer who are much higher risk of heart disease, the combination of cancer and heart disease is even worse. And I know that there is a cardiology department that's working on the heart disease, so those are the patients who are going to be even worse. And this was just the fellow who presented this also just recently won an award at American College of Cardiology as one of the more important papers published in this space. And then again, just highlighting that how our cupboard was so empty, and we've been so blessed to learn a lot from our oncology colleagues. So when people ask us, why are we doing this? Really, the agenda and the aspiration for us is to ring up the wake-up calls. Our research is trying to put things into perspective, give the numbers. When folks say, well, this is not a problem, or we have done enough, or maybe it's getting better, the question is, no, that's not true. This is a real problem where it's under-recognized. Millions of individuals and their families are suffering silently with financial toxicity. And in just the last 5 years, we have clearly shown that what we have seen in oncology, that there is an increased risk of medical death, bankruptcy, significant overall distress, where you may be thinking more about the cost rather than your general needs, psychological distress, lower health quality of life, cost-related medical non-adherence. We are foregoing the much-needed medical care, and also impacts food insecurity. So clearly an issue that we need to think about it. So what's next? Of course, we still have a long way to go and learn from what has been done in the cancer world. I think so that's a great part. But when I look at financial toxicity, and especially within our own community, I wanted to compare it to what happens with weather, because with weather it seems like everybody like to talk about it, but nobody seems to do anything about it. Whereas it seems like all of us wants to do something about financial toxicity, but in our community nobody seems to talk about it. So I think so that's kind of where the first step for us is. We have to start talking about it, acknowledging it, getting all of us on the same table and thinking the best solutions, which I don't truly honestly have right now. I think so the time is really we have to listen and hear the voices of our patients as physicians. The first thing is start asking about financial toxicity. And then again, almost in the same way, it takes less than half a minute to do that. And there are the same solutions and strategies that have been well described in the oncology world can be adopted in the cardiology. The same thing, health systems and communities can come together for finding financial resources. But as we continue to do that, I think this data and all of us here needs to influence our policymakers upstream at some point in limiting the out-of-pocket cost, in making it tied up with some income level, because unless and until we go back to the root of these problems, what we are trying to do are short-term gaps, and which are important, by the way. We need to do that, but at the same time, we all need to come together and impact the policy, and that's where I think so it's so important that institute like this take up the lead on these issues. The other thing is what else we can do. So I just thought about it, wrote an editorial and about the PCSK9 inhibitor, and we will be better off if we take a leaf out of Aristotle's work, which was really refined in the 16th century by St. Thomas on this concept, just price, which is of moral necessity. Price should equate or follow what the worth is and the value, and this can be done for almost anything, any medication, any test. And who is going to define that value? In this society, of course, we want to encourage innovation, and that means we shouldn't be paying less, but at the same time, the question is we shouldn't be paying more than it is needed, and who are the ones who are going to decide that? And I'm pushing my own community leaders and organizations like American College of Cardiology and American Heart Association, and that as we have done well for our patients in recommending therapies, procedures that are much needed and save life, but I think so we have shied away from our own responsibilities as physicians about talking about just price. And thanks to all the efforts that happening at MD Anderson and Duke and other places, we have an example to follow. And I think it has to start with us emphasizing the value and us overcoming the reluctance where we say we are not health economists, we are not there to recommend prices, but I think we have to find ways where we are suggesting what does a medication that causes 20% reduction in the risk of a heart attack should cost. I think so that's where, and we have to move away from these bland treatment recommendations, which truly are isolated from ground realities. So this is where we are. So I personally feel that in cardiovascular disease, the #1 cause of death, the #1 cause of cost, a truly under-recognized condition exists, and we are at a pivotal junction in history. And we have come a long way over the last 5 years, but clearly we still have much further to go. And when I start looking at the solutions, I think the healthcare system and even our medical education system is not constructed in a way to address this. We really need to overhaul it, and we cannot keep on doing the same, trying to address the same, I would say using the same strategies to address different challenges. And of course, if we keep on doing the same thing, failure is doomed. And that's not an option. What we truly also need is unity. And unity, when I say unity, is health systems, communities members, researchers, policymakers, industry. We all need to get on the same table with mind of our most important stakeholder, which is the patient. Really, what does value means? And and if we are able to go through, I truly think that we can make this huge leap in reaching out our goals of social justice and ensuring that there is financial equity that happens, and this then can truly cascade not only through our ecosystem among us, but also within our society. But that's what is needed. We need to start speaking. I think so the data should speak by itself. It has to impact the policymakers and the advocates that we can start making those wholesome changes. But in the interim, the health systems, the community, the patients, and physicians, we all need to find out what are the interim solutions. Because already there is an increased risk of heart disease, of people dying from that. And just because you have a heart attack, the cost of surviving should not give you another one. And that's kind of the goal out here. And honestly, we have so much to learn from our oncology colleagues out here, and it's really a blessing and a humbling experience to learn what it is, and hopefully we can join hands and do more for our community and the rest of the society. So thank you so much for your attention.
You know, when I think about when I started my career decades ago, how things have changed. At that point, the physicians would go to an economist and say, we realize we have a cost problem. How do we fix it? Whereas we've now evolved to the stage where the physicians are directly involved in terms of dealing with the costs of paying for care. So it may not seem like it to you, but this is incredibly revolutionary to me, and it's extremely important because I don't have the clinical knowledge of either of these physicians, so my suggestions on how to fix things are not as, I guess, flexible or effective. So thank you both for excellent presentations and really integrating all the clinical care in to make this you know, I think there's a lot of meat that we can discuss. We're not going to be able to cover it all today. So I'm going to be asking questions, but by all means, if either of you have questions for the other, just jump in. So, you know, I did want to ask more about, because you are physicians and you have encountered, oh dear, sorry, you have encountered patients who are low income. I just want to talk a little bit more about what that's like for you. You did mention how there are actually some guidelines and advice, Ani, that you know you've written out about and published in terms of things to ask, a screening tool, and then various different types of advice. How much further do you go beyond, for example, switching more to generics? Do you actually then just sort of recommend different treatments? For example, you know, it may be more expensive to do the chemo and the surgery, and so you say, well, you know, we're just going to go surgery with you?
Yeah, great question. So the way I'll answer that is to say that in many ways, it's a question of values, right? And specifically patient-born values. And the way this plays out is, ideally, every encounter, cardiology, oncology, endocrinology, should really have as its center a shared decision-making process, right? So what that is a patient and his or her caregiver sort of articulates sort of what are their preferences, what are their goals, and what are their values. And our job as clinicians is to really create a treatment plan that is aligned with that. So to answer your question, Vivian, I think where we should be getting to and what we strive to work towards is get an understanding of, and my practice is sort of plastic surgery, a lot of these treatment decisions, survival decisions are not within my responsibility center because I'm a reconstructive surgeon. But I think even within that, the goal is to say, okay, Mrs. Jane Doe or Mr. John Smith, this is where you are. What are your priorities? Is it life extension? Is it quality of life? Is it minimizing hardship? Is it less downtime? And then our charge is to say, okay, within these boundary conditions, this is a treatment plan that is most aligned with that. And that really extends to toxicity discussions as it does to the intensity of treatment. So that's the way I think we should approach all of this is, in many ways, financial toxicity is a big one, but it's just one sort of like outcome of a treatment journey. And the question is contextualizing with the patient's value system, where does that fall? And if the hierarchy is toxicity, avoiding that is number one, and our goal is to sort of really engender that outcome, avoidance of toxicity. So the way I answer your question is, the next step is a shared decision-making process that has, if appropriate for the patient and his or her sort of like family, really engendering the outcome they want to get. And if it's avoiding toxicity, we do just that.
So you actually have encountered low-income patients that say, I can't afford that, and you know that that's going to lead to lower life expectancy. And you respect that decision.
Yeah, so the short answer is, given my role as a reconstructive surgeon, it doesn't play out in those terms. How it does play out is a patient who either due to where they live, so like I live in Mississippi, so there's a travel burden in seeking care with me, or they don't want to get an intensive treatment platform, so they want to have this really complicated, intensive sort of reconstructive surgery that involves a long length of stay. Why? Because they'll have to like be out of town, disrupt their caregiver. That's toxicity. So the conversation that I have is really mitigating that type of outcome.
I see.
Yeah.
I see. Karam, did you want to talk about that as well?
What you just pointed out, I deal in a different framework, not with urgent life and death situations, more around preventing heart disease. Whether you already have an established heart disease, how can we prevent it progression to a heart failure or a repeat heart disease, or you are at a pretty increased risk over the next 5 years, lifestyle management and medications. But what you just pointed out, shared decision making, it has to be this, I would say, the foundational construct of how we decide. But unfortunately, if you look at it, there is no standards around shared decision making. So it all depends on what you consider or I consider, and we are able to share the information. Of course, we are well taught to have a conversation about medications and their side effects, but how do we bring in the cost issue? Now, even from a patient perspective, does bringing the cost discussion, could that indicate that they may have a perception of getting a low quality care? We don't know. How do we contextualize all of this? So the thing is, we are literally at a ground zero where we don't have good guidance on how to do that. And we are all trying in our own, and I have no idea what I'm trying to do, is that even the right approach or not? Honestly, I have no idea. But the cost truly comes into the play, and one of the key things is that in individuals who need those medications and are unable to do, then we can shift to other medications which are generic that may have some additional benefit, but not as much. And as long as the patient understands, I think so there are significant financial support resources that exist within the system. For example, working directly with industry for financial assistance programs are there. Very cumbersome, takes a lot of time, effort. You need a structure to have that. There are financial support systems within our own health systems and within our own community. But I would say that at this stage, if you ask me what is the right way, I have no answer about that. I try at my level best, and I'm trying to convey that to our physician community, but we have to start bringing this change much early on in our medical education. We're taught to diagnose, have the differential diagnosis, the list of that, but when are we going to start thinking about the social determinants of health? How do we have the cost construct? And that needs to cascade through our residency trainings and the fellowship, because I think the train has left. I'm not too convinced that we'll be able to make wholesome changes in the existing structure, but we still have an opportunity to really bring that mindset in the next generation. So that's where I am. I think so it's a great space for further research and collaboration to standardize it, because there are no standards that exist so far.
So can I just jump on, sort of take a dovetail off of these comments that Kuram made? I think it's really, really important what Kuram just said. Number one, to the best of my knowledge, and I'm several years removed from medical school, but no one is trained in medical school to have these discussions, right? So there's a competency gap there, right? I think it's not just having a cost discussion, it's having an effective cost discussion. But what I just pointed out, though, it needs to take 33 seconds, and our role is not to have this really in-depth discussion, but it's to really surface these issues and redirect to appropriate services, which most sort of like cancer centers, academic medical centers have in place. But there's a competency gap, or a perceived competency gap. That's number one. The second thing I'll say is, if you take a step back and take the physician's perspective, and there's pretty compelling data, national surveys of surgical oncologists. So one reason why sort of a lot of surgical oncologists do not have cost conversation is a perception, a worry that if you have those discussions, you will dissuade a patient from a potentially life-maximizing treatment, right? So that gets into really and I think is extremely valid, our charge, the Hippocratic oath we took as physicians, which is to really extend and maximize life. So that invites some conflict, is if I have this discussion with a patient, male or female, about costs, and it dissuades them from what we believe, randomized control trial evidence, is the best course of care, that invites some internal conflict. And I think, if we're humble and humane, we can see how many physicians are appropriately conflicted. So this is not an easy issue to wrestle with. And the last thing I'll say is the idea of whose values should drive, for me, that's actually clear. It's the patient's, right? So I think the way you get around this is you reorganize the decision-making around the patient. Our charge is to best inform them, help contextualize for them, but ultimately the patient should be empowered to articulate and say, for me, this is what matters the most. And then we sort of act accordingly with respect to a treatment plan.
That's interesting you say that. Several years ago, I was invited over to MD Anderson to give a lecture to the residents about how you do economic evaluation. So I run through all the basics of it. And then I'm walking out with one of the residents. She goes, "Oh, that was a great talk, really, really helpful." They don't tell me anything about the cost of the medications that I prescribe here. I have no idea what they cost. Right. I wonder, has that changed? For example, Karam, everyone, PCSK9 is expensive, and the generics are cheaper. But do you have an idea? Do they tell you if you have I would think if you had an electronic health record, it knows what type of insurance you have, so it knows whether you've met the deductible and how high it is. It should be able to spit out to you easily, this is how much this patient is going to have to pay out of pocket if you want to prescribe such and such. Is that kind of information available to you now, and the costs of the chemos and? Or do you even have? You don't have time. You don't have 30 minutes to look this all up.
Not available. But studies have clearly shown that in EMR, when the cost is available for testing or usual tests that have been done, there is a slight reduction in ordering of that test by the residents, interns, and fellows. I think so the cost needs to go in, but it truly gets pretty complicated in the sense that based on your insurance and your contracts for the same test, same medication, the medication prices may not be that differential, that you may have differential out-of-pocket costs. One thing for the good part that has at least happened, and I'm not really sure how much that affects the oncology medications, at least there are copay programs for the non-Medicare patients. But the Medicare really becomes more challenging unless and until you're able to meet the deductibles. It could be anywhere from $300 to $75. So those are the kind of the challenges that exist. Now the question is that within the 15 to 20 minutes of the patient visit, how much time and effort that we can afford. But as you pointed out, these are the kind of the conversation, the information should be available to the patients. And I truly like the idea, Vivian, as you pointed out, if on EMR or even on your apps, some of those information can be tied, and it shouldn't be that hard, can inform the patient of the choices and even having those conversations with the physicians. So thanks for giving that idea. We'll definitely follow up on that.
So like everything else, no easy answers. So there's been a lot of great work done at Penn, Kevin Volp's shop, sort of showing that sort of price information, and we've done similar work actually in the surgical space at MD Anderson successfully as well, does indeed sort of drive behavior. Unclear how durable that change is. That's the first thing I'll say. The second thing I'll say is, to be honest, and if I'm being quite humble, I don't know and there's evidence to play this out, that patients are discerning shoppers of value, right? So specifically in healthcare, I don't know that price is a strong signal for value, A, so that's an upstream problem. And number two, people have shown, actually, quite compellingly, that if you sort of allow patients to shop, they tend not to track towards the high value item. They don't consume it in a way that is commensurate with what you're trying to engender. So it's like I said, it's pretty complicated. So that gets into financial literacy, gets into health literacy. Unfortunately, I raise more questions than solutions, but I'll say it's actually not that straightforward. And without getting into politics, although you could say healthcare is a political decision in many ways in this country, sort of the last administration has probably done in modern lifetime the most to advance price transparency efforts, actually. So Donald Trump, Republican or Democrat, I'm Democrat, you have to acknowledge that he has done a fair bit of work with respect to price transparency, but it's not really moved the needle despite federal mandates in this regard. So it's a sticky problem that I just think we have to think about reinforcing frameworks across the payer level, delivery system level, patient level, physician level to get to the answer.
Yeah, right. I agree with a lot of what you said. Although I do think there's just no reason why we shouldn't allow Medicare to be negotiating our drug prices for us, and that would lead to lower prices. But so following up on that, it's always been my impression when a drug company is pricing a new drug, they do use some cost effectiveness numbers. So they estimate the quality adjusted life years and say, look, and so given that this is the value of the drug, we're going to go ahead and price it super high. And most of the time they get away with it. But then the problem is after it gets approved, then they raise the price even more. Now, I used to do a lot of cost effectiveness of cardiovascular drugs early in my career. I haven't done that. Why isn't anyone going back and redoing the calculations with the higher price and just showing, the qualities associated with this drug, with this higher price are no longer worth it? Or for, these low-income patients, if you calculate the increase in qualities and make an argument, in some cases, this is beneficial for these low-income patients, and this is why we should be giving them more generous subsidies than is in the average policy, because it actually creates value overall for society.
So in cardiovascular, of course, we didn't have much challenges till the early 2015 when the new cardiometabolic and the PCSK9 came. And when the PCSK9 inhibitor hit the market, they priced it $14,000. There wasn't any cost-effective analysis. I think so a year and a half later, that summer was pretty hot for them because we had 3 back-to-back cost-effective analysis. We were part of one that got published in JAMA that clearly showed. Now, looking from a societal perspective, qualities and life extension and everything, the price should be around $5,000 to $6,000 at the most. That's the upper limit. But the problem is whose pocket it is coming from, because in this country, most of us are not probably in the Medicare phase, and the question is, should we be looking at the life extension? And the challenges that happen with these type of is, what happens in 5 years when there is a new medication comes in? Are the prices going down? So the net present value is also an important issue. And even if the price is cost effective, as they have done in Canada, what are the budget implications? Because if you can get X amount of individuals and reduce X, Y amount of heart attacks, that will result in about $5 million saving, but you will have to spend almost $200 million right now to achieve that. So it's not only about the cost implication, it's about the budget implications, and really there are no right good solutions out here. But that's why the concept of just price, that it should reflect the worth. What does 15 or 20% risk reduction means to the society? And we, as I would say, within the academic community and the health system, needs to define that and work with our community. What are you willing to pay? Bring the patient back, because in the end, I have no idea what should we be willing to pay for preventing one heart attack. And that should decide, or should we take a portion of that and go for preventing road accidents or preventing hypertension? So how do we justify, even when you have cost effectiveness suggesting that they meet, the budgetary implications are pretty challenging. And now we have started to face the same challenges that your community has been dealing for a long time, but I don't find even any right solutions there too.
So, I'll first lead off by acknowledging this is not my core expertise, so I'll lead with that. So that's the caveat for everything I'm going to say afterwards. So the first thing is, number one, as a society, we've decided to not really leverage cost-effectiveness analysis to inform drug pricing, right? So that's something that's done quite well in Europe, particularly the UK with the NICE. Germany as well has a similar framework. So that's where we are as a society. So the cost of drugs is really the cost that the market will bear. That's sort of where we are. In oncology, it's pretty interesting. If you see, a lot of the measures that are used to sort of drive drug approval from the FDA are really surrogate measures, actually, and not really the hard endpoints of long-term survival and everything else. And when those drugs hit the market, there's no fair audit process to see, okay, do you really get the bang for the buck for these drugs? So that's sort of where we are as a system. I will say that the recent decision by Medicare to not cover in a blanket fashion the Aldoham drug is really interesting and I'll say encouraging. And we'll see how the field moves forward. But in many ways, financial toxicity, drug pricing, and I'll say this is really my position, is they point to market failure, and market failures tend to really signal the role for government. That's the way I think of it. I think market failure is not meant to be addressed by payers, it's not meant to be addressed by health systems, certainly not meant to be addressed by patients. It's the role for government to step in and address inefficiencies and or gaps, right? And whether that's mandating sort of like direct negotiation for Medicare with respect to oncology drugs, of which Medicare is the biggest buyer of oncology drugs, that's a government decision, right? Whether we want to index launch prices of medications relative to benefit or value, that is a role for government. So I think not to pass the buck down, but that's sort of how I perceive these things.
Right. Yeah. Look, I agree there's a role for government, but Karan makes an interesting suggestion. I don't think we have talked with the public enough and about how much are you willing to pay. We actually could present the trade-offs to the public and say, are you willing to pay this much to reduce the risk of mortality, or reduce mortality by so much using these particular interventions? I mean, something much more narrower, because we've arbitrarily, this, 30 years ago, they said, okay, we pay $50,000 a year, and that saves someone who has, for dialysis, so that's cost effective. And we're just, because we've agreed we're gonna do that, then everything below that is cost effective. And Aduhelm is the upper limit, but, we need to start asking people more directly. And I think employers should too, because our health insurance is getting out of control as well. I think that's what's driving up a lot of the increases in costs. So let me ask, did you want to say one more thing?
So can I amend that slightly? So these are the costs we already pay, right? We're already paying these costs in our taxes, in our premiums, and it's going up and up and up and up. And indirectly, so it's all a zero-sum pie, right? The money we spend on healthcare is less money available for education, it's less money available for infrastructure. So we're paying these costs already. It's just somewhat invincible, it's not front of mind. So I think the framing, I'll suggest, to be much more expansive to say, look, we're already paying these costs. What are we getting for these costs we're paying for?
Yeah, absolutely. And we have to sort of, again, more transparency of a different sort.
Vivian, there is significant waste happening too around us. And one thing that has always intrigued me is how much do we spend? And it's a very back of the hand calculation. So I pay $100 to, let's say, United. And as a health system, then the health system spends $20 to get $40 back from that. And in the end, they end to keep up the $20 to $30 just managing the transactions. And for me is, why can't large health systems, and there are models like UPMC and other, where we can go back to the community and say, we can provide you the same service for $80. and we take that out, and actually there is more dollar back to the health system to do what is supposed to do, take care of the patient. So I think so those are kind of the models where those folks in this whole journey, the middle men and women who are squeezing out and adding no values, PBMs, insurance companies, and all of those that can help significantly reduce the burden. And actually, without even going with the government interventions, of course we need that too, that there are solutions that have not been thought about. So those are extra things that we need to have some more conversations around.
Yeah. Oh, yeah, absolutely. So I'm just going to ask them one more question, and then I'm going to open it up to questions from the audience. So agreed. Insurers, plenty of waste going on. Administrative service only contracts. Listen to the podcast Trade-Off. There's a really good episode on that. How the ASO is actually not finding the cheapest prices for the employees. They're actually, making money off themselves. PBMs, it's clear. It just seems that all they do is hide their prices with transparency. They're getting all sorts of rebate. They're supposed to be saving the employer money on the employee's drug costs. They don't do that. But you two are with Methodist and MD Anderson. Okay, so in my other work, I've been working NASHP, National Academy for State Health Policy. They've made the Medicare cost reports very user-friendly. It's now posted their NASHP hospital cost tool. And you look at the numbers from those. Your two health systems, Methodist and MD Anderson, are quite profitable. Actually you look at the cash reserves. MD Anderson, most recent cost report available, it's close to 10 billion. Methodist is 5 billion. And you look at the research coming out of Johns Hopkins, GBI, Jerry Anderson, they compare nonprofit hospitals, charity care as a percentage of their expenses, and they find the rate for nonprofit hospitals is half that of for-profits. It should be the other way around because the nonprofits are not paying taxes and the for-profits are. So there's this question of, it seems there are substantial profits. Why is that not going towards these patients with financial toxicity? Or does there, and more, we're about policy here. I have my ideas about, what should be done in terms of policy, but, I'm just sort of curious to hear your.
Vivian, I'm happy we're talking about it. As I said, we need all to get together on the same table, like community leaders in this, within Houston, and health systems as leaders, and policymakers and industry. We all need to talk about it. And I'm happy we are having these conversations. I'm definitely seeing a slight realization in this area, especially, and again, I've been at Methodist for a couple of years, is realization in the leadership, realization in the operational leadership that we need to do more, and especially around dealing with low-income individuals, more vulnerable communities, members of our society, addressing the social determinants, having partnership with these community leaders. And there is definitely a trend that's happening. As you know, these are big ships. It takes time to move in the right direction, but a great example would be just in the last year and a half, almost a $25 to $50 million commitment to truly build models and programs around social determinants of health, incorporation and having discussion of financial toxicity, programs within the system around financial navigation. Now, the cost and the prices is always a challenging issue that's most of the time beyond within the physician's, I would say, decision making. But I think having these conversations, we need to also encourage and be part of that. But I think so we have a great opportunity out here with Baker, MD Anderson, Houston Methodist, and rest of the community health systems coming together to address this together.
Yeah, and sort of couple of things I want to just add. First of all, these are all mission-based organizations, right? At the end of the day, without a doubt, there's a strong commitment to these larger systemic issues on both institutions. Second thing I'll say is, and with that as a canvas, is I do think we are doing meaningful work in this domain, whether at MD Anderson is partnering with LBJ, to support the radiation oncology and medical oncology programs there, whether it's collaboration with sort of community-based entities or across the UT system. But this is a sticky problem, and no one institution will quite crack the nut. And certainly there's a role for policy, for research, and I do think our institutions are moving in that direction. We'll just have to see how it plays out and how meaningful change is able to be affected by the ongoing efforts and hopefully new efforts in this space.
Although MD Anderson could take more Medicaid patients. All right. So
We could all do more.
We
You're
could all do
Yes.
more.
Yeah.
We could all do
yes,
more.
definitely. All right, so with that, I'd like to open it up to audience questions. We're recording this, so if you have a question, please raise your hand and a microphone will be brought over to you. And if you feel comfortable, say like where you're from, or for the benefits of our speakers.
I have a question. My name is Lisa Lipscomb, and I am retired from Baylor from doing dementia research and worked on Aduhelm's development. And of course, I now pay a higher Part B premium because of Aduhelm's approval and question its benefit. But the question that I have is about payment plans. So when you owe a hospital something, many times you can set up a payment plan, and it's been my understanding that as long as you say you'll pay something, that they will not come back at you, ruin your credit score. And I'm just wondering if your patients know that your institutions have that kind of a policy where as long as you agree to pay something every month, they accept that. And I suppose that's probably a problem. You don't want to encourage your patients to not pay their bill in full, but I just wondered what the institutions tell you about what you're allowed to tell patients about that kind of a payment plan.
So I'll lead off first. So these are all big institutions. So a lot of these policies are not diffused to every physician, right? So it's a lot to be responsible for. That's number one. Number two, new law in the last month that I actually think medical bills are no longer reported or impact your credit score. So at a national level, once again, policy, right? It addresses that problem. So that is no longer a problem, I believe, moving forward, actually, creditworthiness as impacted by medical bills. So that's sort of where we stand. And I'll admit personally, I was unaware that sort of institutions had that policy in place. And I can't speak for MD Anderson. I'm not aware of what our policy is, our position is. But all I have to say is, sort of clinicians are juggling a lot, right? The layers of clinical evidence, right? Patient care, burnout is high. So I think that we need to think about these things holistically and create structures and policies where no one entity, no one hospital has to solve all of this, right? Certainly.
Don't have much to add what you just said. I don't know about policies that are disseminated, but if you look at the national data, almost 50% of patients with heart disease are anyways paying it forward either through credit, asking from friends, or having those conversations with the hospital with some arrangement. So it's widespread. We don't know locally how much and what are the processes. But as you pointed out, in the limited scope and the time and what we can really make an impact, screening is the most important thing that I personally tend to do. And in the significant amount of the patients where we find that they have challenges, I connect them to some of the local resources that we already have that help them through the financial navigation process. Now, it's a great question of what happens next, but definitely I'm motivated to learn more when I go back. So that's a great thought. Thank you so much for that.
Same here as well.
Hey, good morning. Thanks. Great talk. I'm Eddie Patton, neurologist, and we'll be back with the UT system on Monday, as a matter of fact. I start on Monday. But my question, I want to follow up on some of the comments that you were just talking about preventative care when we look at this financial toxicity question. Throughout different things, cancer, neurology, everything else, a lot of those costs go up because it's catastrophic care. It's at the end stage of these diseases. How do we assess value to preventive care? Because I'm pretty sure that if you go out to the YMCA and establish a walking club and talk about diet, you can prevent a lot of those downstream costs as far as catheterizations and that kind of thing. You may not see that until 5 or 10 years later, but you're not paid for that. You're paid for seeing patients in the clinic. So how does preventative care and the payment for preventative care fit into this?
So I think that, you know, insurance and capitated models are really catching up to some of those things where provision of services, lifestyle, gyms, exercise program, cooking classes, home care are getting into that. But this won't happen within the true insurance model where you and I or others are most likely going to shift from one insurance to another. That's an average that happens over the next 4 years. So the whole question is, whose pocket is it coming out of from? And that's kind of the key question, which you're going to see a lot in the Medicare Advantage program. I think so the Medicare can take a lot of that effort. But in the short period of time, I think so one, precision medicine truly helps in making those decisions, because we may have 100 people in this room who may be candidate for preventive therapies apart from lifestyle management, but who is truly at risk. And by some of these precision tools, for example, just a simple heart scan that tells you whether you have plaque and how much plaque you have, can truly identify the 25% where we need to spend versus the rest where we can have flexible. So I would say interplay of public health, local communities, payers needs to come in and work for the long-term preventive models, as you pointed out. But within the short-term preventive models, there is a role for precision medicine where there is an ROI of the upstream investments.
I think that's a fantastic question, and have little to add to Karan's phenomenal response. I would say, in my opinion, the most cost-effective care is preventive care, by far. No matter how you slice it, whatever perspective.
But we spend 5% of that in
True,
this nation.
right? So there raises a second point, which is, as a society, as a payer healthcare payment system, we actually reimburse for health care and not health, right? Those are two different things. So we don't really reimburse in a way commensurate with value, wellness, preventive services. We just don't, right? We really reimburse for acute care consumption in the hospital, in the surgery center, in the catheterization lab. So that is where we are as a society. And without speaking for payers, if you think about it, why would, just being honest, a commercial payer really index on preventive services for me when those benefits will be likely play out on a 10, 15-year horizon, right? So in a world where we have gig economy, people change jobs, right? If your payer is anchored to your job and you churn, right, they don't see the benefit for it, right? So the time horizon and the fact there's a ton of churn really begin to set up why we have what we have, right? And I think, to my earlier comment, that is a solution or problem that's best addressed by government policy level.
And
Yeah,
by
you
the
know,
way,
Elena Marks, who's a non-resident fellow here, she's just retiring, stepping down as the CEO of the Episcopal Health Foundation, and she has a really great talk it's on our YouTube channel on health and not health care. And so her approach to this, because she was in charge of a very large endowment, and all the healthcare systems came up to her and said, oh, you need to give us funding to treat all of these sick patients. And her response was, no, we work upstream. So her approach was, I'm going to invest in the things that lead to a better environment, a healthy environment. We're talking about parks, we're talking about interventions that improve schooling for children, nutrition, all these things. So really working upstream on these preventive things. I'm not a big fan of these, let's pay for health clubs for everybody who has a health insurance policy, because all that does is it gets the people to exercise who are going to exercise anyways. That you really have to work very far upstream in order to get good payoffs.
Right, so 80% of health outcomes are driven by these non-medical things, the behaviors, right? So then how do you create a framework to pay for transportation, to pay for food insecurity, to pay for stable housing? So it's a really sticky problem to address, but that gets at why no one has, it was easy, it would have been done by now, right? So how do we pay for these social determinants of health, gets to wellness, gets to health, and it's just a really tough problem. So like I said, more questions than answers, unfortunately.
My name's Kyle Christopher. I'm with a company, MRG Health and Smart Care 360. We're a disease-specific and virtual care management platform. There's been so much new legislation and care models and payment models that have been released, I guess, by CMS over the past 2-3 years. A lot of healthcare organizations or executives are just not aware of the new models that kind of have met the technology advancements. That's what we've learned. How do people in kind of your roles or physicians or even healthcare executives stay up to speed with those new types of models that are providing in-home care, in-home hospital capabilities? Is there kind of, I guess, departments or individuals that kind of focus on the new legislation that aligns with a lot of these problems?
This is right up your alley.
Health transformation.
It is. So I'll say that the jury is out, the word is out. I think there's no mystery to a lot of these new models, right? Whether it's virtual care, remote monitoring, hospital at home, I think most institutions are aware of them. So take acute hospital at home, one I know fairly well. As of March, well over 200 institutions across 36 states are doing this model, right? So, and I think sort of in reading the market, the signals have always been there, quite frankly. And what you have with COVID is a forcing function that really got us to say, okay, you know what, we gotta jump on this train. So I don't think it's a lack of awareness. What I will say, and I've published on this, is these new models are actually extremely difficult to implement right and scale, right? So take hospital at home, a lot of excitement, certainly on my part, but there's also novel risks from a data privacy standpoint, from a legal attribution standpoint, with respect to these models that we really need to think through thoughtfully, because at the end of the day, this is not Uber or Netflix, this is actually lives and care delivery. So I think we need to approach them with considerable more moderation and humility. And I'm not to say that we are not, but certainly I think the stakes are pretty high. So I actually wrote about this in Nature about 2 months ago, that this new paradigm need, in many ways, a new governance framework to think about them, right? And a new legal construct to address them effectively. So whether it's a caregiver, whether it's a third-party entity, on the technology side, on the health system side, there are new risks with these models. How do we think about them to really dampen I think, the potential for significant harm? So short answer is yes, health systems are aware, for sure. And the question is, how do we implement this in a way that is holistic, that is patient-centered, and really drives outcomes?
One last question.
I'm David Newberger. I'm a fan of Baker and all the things that Vivian does. I had a prostate cancer surgery at MD Anderson. Nobody sat down with me when they were going through all the kind of testing and things I would have. Nobody sat down with me and said, well, this is going to cost X. If you have insurance, it's going to be this price. And they didn't tell me what the different options were as far as the costs go, because I didn't have to have surgery. I could have done other kinds of treatment. But so my question really is, in this whole process, how sensitive is the leadership in the hospital to this issue? I think Vivian made the statement that Vivian made about the resources of these institutions is very striking. That's A. And secondly, with all the work you've done on the cost of all the cost of all these things, has anybody looked at the actual cost of providing these services, so you understand whether the program that you're giving this patient, whether that program is generating a profit for the hospital or a loss for the hospital, and therefore trying to adjust the way you charge for things so that you can, in the case of being a nonprofit, why shouldn't the nonprofit's service to a patient basically be zero? The whole idea of this is a nonprofit, and you're not in to make money. You're there to provide a service, and that cost of that service should equal, the whole benefit of the thing. So anyway, is there any attempt made to try to understand the cost of these services, you're spending a lot of time on the revenue that's coming from all this process, but what about understanding the cost of what goes on?
So there's a lot there. So let's start with that. So I'll say the first stem that you prompted is, our leadership sensitive to this? Yes. I think, especially in oncology, we cannot help but see the trends and see the publications and read the stories, whether it's in Washington Post, New York Times, Kaiser Family Foundation. So I'll say health systems, including ours, are responding appropriately to what is a significant issue in this space. With respect to costs, so I'll say one thing that I would like to say. There's a lot of imprecision in language. So there's cost. I think we should talk about cost to whom, like who's bearing the cost. And then there's cost of what? Is it an episode of care? Is it a specific procedure? And even on the health system side, there is, so nonprofit, profit, hospital doesn't make a difference. There's a margin incentive, right? You need to make margin to keep the lights on, to deliver care. So I think this space, it's really complicated. There's a lot at play here. Certainly, I'm in no position to answer on behalf of MD Anderson. What I can say is, number one, we are sensitive to the cost and how it plays out for our patients. And most systems, MD Anderson, Methodist, anyone, Sloan, Hopkins, Baylor, we all are moving in direction to really dampen and sort of like mitigate this experience for patients, because like I showed, it has a survival outcome, an adverse survival outcome. So it directly, to my first image, impacts the therapeutic alliance between a doctor or a health system and a patient. Now, with respect to, you said studying the total, I'm assuming the total episode of care. In oncology, is a little bit different, right? Because the episode of care in oncology sort of traverses from diagnosis to treatment to survivorship. So what sort of like vertical are we looking at? And certainly with respect to our work, my group is certainly not looking at that, right? I think sort of it's not that straightforward to do. So I didn't present our work, but a lot of our work is focused on the patient experience, so the psychosocial impacts of financial toxicity. And we use a lot of survey-based data to do a full episode. To my knowledge, it'd be really tough to get a data set that cuts across all payers, cuts across an entire episode of care. It doesn't exist, actually. So to get at this information is actually not that straightforward, at least for me. And in the work I saw from you with the MEPS, it was basically survey-based analysis, sort of what we're doing. And for my work, we're really focused on the acute episode of care around surgery. But that does not really speak to the entire totality of sort of the patient experience with cancer services.
Okay, I'd like to be respectful of our audience's time. Thank you so much for coming, and this is just the first of many events. As Rula said, we've got more coming. I'd like to thank both our speakers. You know, these are really tough questions that we are addressing, but you know, it's clear to me both Ani and Karam care deeply about their patients and the financial challenges we're facing, and I'm sure we're probably going to come back and revisit this issue.
Oh, yeah.
You know,
It's just a start.
this is just the start. So thank you very much.
Thank you.
Thank you.